Imagine never being able to express your true feelings. Or if you did let your frustration or anger out, everyone around you would brush you off and tell you that you can't control yourself. Nothing you say will be taken seriously, and sometimes you may even start to doubt yourself. Am I being overdramatic? Am I actually upset, or is my body making me upset? Am I acting this way because of my period? I've been here before many, many times. About 1 week before my period starts, I will start experiencing emotional and mental symptoms of PMS, premenstrual syndrome. When I'm PMSing, my temper gets shorter, my polite filter comes off, and my boyfriend gets way more annoying. And I've wondered before if these things that get under my skin are only bothering me because I'm about to start my period. But many researchers argue that the emotional and mental symptoms of PMS are actually a social construct. So they theorize that during this week before menstruation, I will subconsciously let myself show my anger and frustration because it's the only time that this behavior is socially acceptable for a woman. There are many physical symptoms that come with menstruation, like headaches, abdominal cramps, back pain, fatigue, bloating, and acne. However, roughly 75% of people menstruating also experience physical and emotional symptoms due to PMS, although the percentage varies widely from 20 to 90% depending on your source. PMS occurs before the start of a menstrual period and ends when the cycle begins. Physical symptoms are similar to those experienced during menstruation, such as swollen or tender breasts, cramping, back pain, and headaches. Emotional or mental symptoms vary, but can include irritability, mood swings, depression, anxiety, sleep problems, among many others. Premenstrual dysphoric disorder, or PMDD, is considered a severe form of PMS, and it affects a smaller percentage of menstruating people, about 5 to 8%. PMDD is often misdiagnosed or underdiagnosed because of the lack of consensus on needed symptoms. However, the DSM-5, the American Psychiatric Association's most recent edition of the Diagnostic and Statistical Manual of Mental Disorders, lists specific criteria for diagnosing PMDD that is based on 4 core mood symptoms, the total number of symptoms, and the timing. To meet the criteria for PMDD, you need to experience one of the 4 core mood symptoms: extreme irritability or anger, notable feelings for depression, intense anxiety or stress, and avoidance of usual activities. You also need to experience a total of 5 of the other criteria listed in the DSM, including symptoms like difficulty concentrating, fatigue, or change in appetite. While the criteria for PMDD and symptoms of PMS seem very concrete, everyone experiences them differently. Some people consistently experience other symptoms not listed in the DSM, or a different combination or severity of symptoms each cycle. Experts and researchers also disagree on the etiology or cause of these syndromes that dates back to the discovery of hormones and the classification of PMS. You may already be familiar with the term hysteria that dates all the way back to ancient Greece. Throughout history, hysteria was deemed an illness that only affected people with a uterus, typically women, and has been used to undermine and discredit women for centuries. In ancient Greece, they believed that a uterus could migrate around the female body and place pressure on other organs, causing female problems. Other causes were credited to the presence of menstrual blood in the uterus. The proposed treatment for retained menstrual blood was sexual intercourse and, of course, marriage first. In 1835, a British physician named James Cowell Pritchard wrote, "Some females at the period of catamenia undergo a considerable degree of nervous excitement. Morbid dispositions of mind are displayed by them at these times. A wayward and capricious temper, excitability in the feelings, irritability, a proneness to quarrel with their dearest relatives, and sometimes a dejection of mind approaching to melancholia." This description of what was understood to be hysteria, or what we know today to be PMS, demonstrates the level of misunderstanding that people had of women's menstrual cycles and the origin of some common gender stereotypes like the nagging wife. In 1880, Jean-Martin Charcot, a notable French neurologist who was considered one of the fathers of modern neurology that also studied hysteria patients, gave the term a medical understanding through his lectures and influence. One of his famous students, Sigmund Freud, expanded upon the medical understanding of hysteria through several studies from 1880 to 1915. Freud believed that hysteria was a result not of a physical injury in the body, but of a psychological scar produced through trauma or repression. Freud speculated that this trauma was due to a woman's Oedipal moment of recognition, when a woman realizes that she has no penis. His recommendation for a remedy to this psychological hysteria was also sexual intercourse in marriage, so that a woman could regain her lost penis by marrying one and potentially giving birth to one. As modern scientists were beginning to research and understand the presence of hormones in the human body, two scientists, Edgar Allen and Edward Doisy, focused on studying the hormones of the female reproductive system. The discovery of the estrogen hormone in 1923 would change the way that scientists and medical experts would try to understand the menstrual cycle and resulting symptoms. Premenstrual tension, or PMT, was the predecessor to the term PMS, and the first time that these symptoms were medicalized and seen as biological rather than purely psychological. PMT was coined in 1931 by Dr. Robert T. Frank, and it wasn't until 1953 that Raymond Green and Katharina Dalton coined the term premenstrual syndrome that we still use today. This redefinition came as a response to Frank's term of premenstrual tension, as Green and Dalton argued that PMT is just one part of the overall syndrome of PMS. Dalton, in particular, was considered a pioneer in PMS research, and she would go on to testify as an expert witness during notable court cases that used PMS as a defense. Before discussing the use of PMS as a legal defense in court, it is important to reiterate how the medicalization of PMS symptoms and the inclusion of a PMS-related diagnosis in the DSM legitimizes this type of defense. In 1980, the term hysteria was finally deleted from the official DSM. The predecessor to PMDD, late luteal phase dysphoric disorder, was added to the DSM in 1987, under the category of unspecified mental disorders. LLPDD was replaced by PMDD in 1994. In the most recent release of the DSM, PMDD was given the status of an official diagnosis under depressive disorders. The American Psychiatric Association and the DSM hold a lot of authority and sway in the diagnosing and legitimizing of mental disorders. While the use of PMS and menstrual-related distress is divisive, it has successfully been used to lessen criminal convictions in the past. In 1980 and 1981, two British women, Sandy Craddock and Christine English, in two separate incidents, were able to lessen their conviction from murder to manslaughter based on the testimony of Dr. Katharina Dalton, and the argument that their PMS symptoms diminished their legal responsibility. These women were only two of many defendants that attempted to lessen their convictions with a PMS defense. In 1991, the first successful American-based PMS defense was argued in Virginia. Dr. Geraldine Richter was able to avoid a drunk driving conviction due to the argument by her lawyer that her behavior was consistent with PMS. The PMS legal defense argument is very divisive in the healthcare and feminist communities. On the one hand, this argument reinforces common stereotypes of women as uncontrollable due to their hormones. Using PMS as legal defense could lead to women being denied certain jobs or rights to their children. Supporters of the defense argue that for some women, PMS really does make them uncontrollable, so that should be considered in certain criminal trials. Becky L. Jacobs, a professor of law at the University of Tennessee, analyzes in her law article on PMS as a defense how the DSM diagnosis for PMDD and the use of PMS in legal cases impacts how women are viewed culturally. She states that it raises troubling issues of a cultural tolerance for a biased prototype of woman as deceitful, cunning, manipulative, hysterical, and irrational. Not only does this trivialize the medical aspects of the PMS disorder, it also reinforces hierarchical power structures and subtly justifies intolerance and prejudice. This debate carries over to the inclusion of PMDD in the DSM, as many experts disagree with labeling PMS-related symptoms as a mental disorder, as PMDD is considered a severe form of PMS. Opponents of the DSM inclusion argue that a diagnosis of a mental disorder should not be required for women's anger and distress to be taken seriously, and that PMDD is the modern version of diagnosing women with hysteria. They also argue that the inclusion of PMDD in the DSM reinforces existing stereotypes that women are at the mercy of their hormones during their period, that they aren't responsible for their actions, and that they cannot be trusted in positions of responsibility. Proponents of the inclusion of PMDD in the DSM argue that women diagnosed with PMDD will experience relief at their severe symptoms being recognized and legitimized by an organization like the APA. It also gives medical professionals a guideline for diagnosing PMDD and can help women that have been unheard and misdiagnosed experience comfort and get the medical assistance they need. Although even proponents agree that the medicalization of women's bodies can be harmful in perpetuating stereotypes and that scientific consensus on the etiology of PMS and PMDD has not been reached. There is an alternative view emerging from this debate that might be seen as radical. PMS researchers have been considering the socialization aspect of PMS symptoms for nearly 30 years, and some experts have argued that PMS is a social construct. Gender stereotypes have dictated that women should be passive by nature, so any variation from this, including anger and aggressive feelings, will be considered not normal. We have societally begun to assume that any woman exhibiting irritability or typically non-feminine behaviors must be on her period or experiencing PMS symptoms. This will lead some of us to wonder, am I actually upset or is it just my PMS? Some women even see the time they are experiencing PMS symptoms as the only time they can really be themselves and act the way they want to. American actress and comedian Roseanne Barr is quoted for saying, "Women complain about premenstrual syndrome, but I think of it as the only time of the month that I can be myself." Many women may be able to relate to this, and PMS researchers are continuing to explore this theory of PMS as a social construct. Although, it is important to note that the physical symptoms of PMS are still prevalent for many women, and their pain is real. Every woman is familiar with the stereotypes associated with their PMS symptoms. During that time of the month, women can be witches, uncontrollable, unreasonable, and so much more. By accusing someone of PMSing, their opinions, reasoning, and actions can be devalued because as a society, we are taught that a woman's raging hormones make them completely unreasonable. Talking about menstruation and PMS is deemed taboo for anyone to discuss, and when they do, most people are looked down on as talking about something gross or dirty. Growing up, a lot of women are told not to discuss their period with men because they won't understand or look down on them. This will even follow some of us into adulthood, especially heterosexual women that follow westernized gender roles. One study by Jane Usher and Jeanette Purse, professors at the University of Western Sydney, Australia, focuses on a non-heterosexual perspective of the interactions between women and their partners whilst experiencing PMS symptoms. They interviewed both heterosexual and lesbian women that experienced PMS and their partners to gather information on their dynamics and level of support. Usher and Purse found that the duties expected of heterosexual women due to gender stereotypes exasperated their negative PMS symptoms, as well as an overwhelming lack of support and understanding from their male partners. Notably, they found that the labeling of women's emotions, requests, or criticisms as PMS can thus serve to negate her needs or concerns, which have implications for power imbalances in the relationship and can exasperate premenstrual distress. However, women in lesbian relationships showed better coping strategies for their PMS symptoms and a better support system from their partners. Historically, the male domination of the medical and scientific fields has led to the misunderstanding and dismissal of women and their problems. What was once known as hysteria has transformed in our vernacular to become premenstrual syndrome, and the damaging gender stereotypes have followed. While many women and people with uteruses experience symptoms associated with PMS, the dismissive attitude towards these people and their input has been debilitating for centuries. There is still a lot to be done with determining the real cause of PMS and PMDD, but everyone should be aware of the term sexist history and the stereotypes that are still being perpetuated. It is very hard to answer the question, am I acting this way because of my period? The scientific consensus is not there on whether or not PMS is biological or psychological in origin, but we all know ourselves best. So if you're reacting to something a little more dramatically than normal, maybe it's time to address that underlying problem. We could all benefit from the abolition of gender roles and stereotypes. Showing our emotions is what makes us vulnerable and relatable as humans. A society where we could all be ourselves all the time would be great for everyone. But if we keep doubting ourselves and our loved ones, this will never be a reality. So men, please stop asking your menstruating friends if they are on their period every time they get upset. And women and menstruating people, stop assuming that your PMS is the cause of your emotions and consider that you may just be holding these emotions back the rest of the month.